So, good evening, everyone. Hope you are doing well. In today's session, we are going to discuss my lecture number 80, which will talk about the recently released NICE guidelines released in August 2024, dealing with identification and management of adrenal insufficiency. And we'll try to do these guidelines through case-based scenarios, so that will help us simplify these guidelines and get a better understanding of the same. So let's start right away. So case scenario one is of a 50-year-old man with Addison's disease recently lost his spouse and is experiencing significant emotional distress. He reports feeling extremely fatigued and unable to manage his daily activities. So the question scenario is, what is the most appropriate adjustment to his treatment during this period of psychological stress as per the NICE guidelines NG 243? So option A is no adjustment is needed as psychological stress does not affect the cortisol levels. B is increase the glucocorticoid dose for 1 to 2 days, that is follow the 6-day dosing. Option C is stop glucocorticoid therapy to prevent side effects. Option D is switch to different form of glucocorticoid. And option E is administer mineralocorticoids. So the correct answer here is increase glucocorticoid dose for 1 to 2 days and follow the 6-day dosing even in periods of psychological stress as this patient was experiencing. So this is what has been defined in the latest guidelines. Physiological stress is when a person has fever or a physical trauma requiring medical attention and covers intercurrent illnesses, invasive procedures, surgery and pregnancy, including labor or pregnancy loss. So this is very important that in this case scenarios where we are talking about physiological stress, we are all aware that we need to use the 6-day dosing for this category of patients, and these patients will need a higher dose of steroids during this periods. Now the guidelines stress about even psychological stress. So periods of sudden, intense psychological and emotional stress, for example, a bereavement, appearing for an exam, or significant life events such as getting married or divorced are also contributing to psychological stress, and even this should make us give the patient an increased dose like we do for a 6-day dosing in the event of a physiological stress. So this is what the guideline highlights. Even in periods of psychological stress, we should refer to increasing the glucocorticoid dose for 1 to 2 days and follow the 6-day dosing. So management during physiological stress and adrenal insufficiency is provide additional glucocorticoids, provide extra glucocorticoids for increased dosing during physiological stress and follow the 6-day dosing. For those on modified release hydrocortisone, provide immediate release hydrocortisone. So we offer at least 40 mg of oral hydrocortisone daily in 2 to 4 divided doses, or 10 mg of oral prednisolone daily in 1 to 2 divided doses until the stress resolves. As regards prednisolone dosing, if patient is already on 10 mg or more daily, then split the dose into 2 equal doses, and no additional 6-day dosing, no doses will be required if the patient is already on 10 milligram or more daily of prednisolone. Avoid prolonged dose increases. So do not increase glucocorticoid dosing for extended period of time, and watch out for signs and symptoms of over replacement. As regards vomiting management, for example, if the patient is vomiting, if vomiting within 30 minutes of an oral dose, take a further dose after vomiting subsides at double the original dose. If vomiting recurs, then we should resort to giving intramuscular hydrocortisone and seek emergency care. In the event of a hospital admission, admit if unable to absorb oral glucocorticoids, example prolonged diarrhea or vomiting. In all these case scenarios, patient will need hospital admission and administer 100 mg intramuscularly or IV hydrocortisone. In the event of a severe illness, use 6-day dosing for adrenal insufficiency. If the patient is severely unwell, administer 200 mg IV hydrocortisone over 24 hours as an infusion, or 50 mg IM or IV hydrocortisone 4 times a day. Always get a review from the endocrinology specialist. In the event that the patient is going to undergo a surgical or invasive procedure, then we should aim to provide glucocorticoids IM or IV as per the tables which is mentioned in this set of guidelines, which is from the Woodcock. So, recommended doses for intra and post-operative steroid cover in adults with primary and secondary adrenal insufficiency. This is a busy slide, but again, it's a good overview. So, if the surgery under anesthesia, like general or regional, including joint reduction, endoscopy, or even IVF egg extraction, and even for that matter, we are talking about cesarean section. So, hydrocortisone 100 mg IV on induction. It should be the intraoperative steroid replacement followed by the immediate initiation of a continuous infusion of hydrocortisone 200 milligram for 24 hours. Postoperatively, the hydrocortisone infusion is continued till the patient is nil by mouth, or for patients with postoperative vomiting, alternatively hydrocortisone 50 mg every 6 hours by IM injection can also be given. Then resume enteral, then double dose of hydrocortisone should be given for at least 48 hours or for up to a week following major surgery. If the patient has a rapid recovery, then double the hydrocortisone dose for 24 hours. If the patient is going to undergo any bowel procedures requiring laxatives or enema, then bowel preparation under clinical supervision, consider IV fluids and injected glucocorticoid during preparation, especially for fludrocortisone or vasopressin dependent patients. Hydrocortisone 100 mg IV or intramuscularly at the start of procedure is given. Post procedure, resume enteral double hydrocortisone doses for 24 hours. In the event of a labor or vaginal delivery, hydrocortisone 100 mg IV at the onset of labor, followed by immediate initiation of a infusion at the rate again same of 200 mg for the 24 hours. Alternatively, hydrocortisone 100 mg intramuscularly, followed by 50 mg every 6 hours IM. Post-delivery phase, resume enteral double hydrocortisone doses for the first 48 hours. Cesarean section, as I mentioned, referred to as the surgery under anesthesia, like general or regional. The same principles will apply if the delivery is through cesarean section. As regards babies, children, and young people, those who are under 16 years of age, we need to adhere to the British Society, Pediatric Endocrine Society guidelines for the adrenal insufficiency. That's again an extensive set of guidelines. I will not discuss that in this session. But those particular doses for the intraoperative and postoperative steroid treatment for those between 1 to 16 years of age is mentioned in that set of guidelines. So as I was mentioning, psychological stress, again, it can be any event. Again, I'm mentioning emotional stress, bereavement, exams, significant life events such as getting married or divorced. So the guidelines suggest that in patients age 16 years and over, consider sick day dosing, same as we do for physiological stress, for 1 or 2 days during the psychological stress period as well. Consider sick day dosing at times of severe mental health crisis, for example, a psychotic episode. Consider giving 100 mg of hydrocortisone intramuscularly for a person in severe mental health illness crisis and who is unable to take oral glucocorticoids, like in an event of a psychotic episode. Again, for children, babies, and those up to 16 years of age, we have to again follow the British Society of Pediatric Endocrinology guidelines, which is a specific set of guidelines mentioning the doses for the children and young people up to 16 years of age. As regards non-pharmacological management during the period of stress, education and information is very important. Ensure individuals with or at high risk of adrenal insufficiency, along with their families and carers, understand daily dosing, how to manage their regular medication, sick day rules, adjusting doses during illnesses or stresses, and crisis management steps to be taken in emergencies. So going on to case scenario 2, we have 45-year-old man presents with persistent fatigue, weight loss, salt cravings, and frequent dizziness. When standing, his blood tests reveal low sodium and high potassium levels. By this time, you all know the diagnosis, what is the most appropriate initial diagnostic test for the patient as per the NICE guidelines. So they had given the options of 24-hour urinary free cortisol, random cortisol, ACTH, 8 to 9 AM serum cortisol levels, or a dexamethasone suppression test. As mentioned in the guidelines, the correct and appropriate answer for this case scenario is an 8 to 9 AM serum cortisol level. So the guidelines mention about the initial investigations for adrenal insufficiency. Do not test people on oral glucocorticoids as physiological doses or above. Low 8 to 9 AM cortisol levels may be seen in those on non-oral glucocorticoids as well, like inhaled, intramuscular, or topical. Now, guidelines have defined physiological equivalent doses, which is mentioned in the statement. as the dose of glucocorticoid that is equivalent to the amount that a healthy adrenal gland will normally produce. For people aged 16 years and over, this is a total daily dose of hydrocortisone, 15 mg to 25 mg, prednisolone 3 to 5 mg, or dexamethasone 0.5 mg. For babies, children, and young people under 16 years, this is a total daily dose of hydrocortisone 8 milligram per meter square. The physiological equivalent dose may also vary and depend upon factors such as the weight. But basically, do not test people on oral glucocorticoids at physiological doses or above, because then that will be a spuriously wrong result. So looking at the cutoffs mentioned, again remember that these cutoffs are only for use with modern immunoassays. Local guidelines may need to be followed if alternative assays are used. So for those age 1 year and over with suspected adrenal insufficiency, below 150 in adults, likely adrenal insufficiency, refer to endocrinology and consider treatment. If children and young people, likely adrenal insufficiency, urgent referral to pediatrics or pediatric endocrinology. If the range of serum cortisol, which is an 8 to 9 am serum cortisol, is between 150 to 300, adults uncertain whether it is through adrenal insufficiency, consider repeat the test and seek endocrinology advice. Children and young people, again, it's uncertain at this level and consider repeating the test and seek pediatric endocrinology advice. Above 300, adrenal insufficiency, very unlikely. Special consideration for babies under 1 year, measure cortisol at any time, seek pediatric endocrinology advice. Post glucocorticoid injection, wait for at least 4 weeks before doing a testing. Oral estrogen users, stop estrogen 6 weeks before testing to avoid falsely elevated cortisol level. Switch to other contraception methods or transdermal estrogen if necessary. If we are suspecting an adrenal crisis in oral estrogen users, then do not wait, measure the serum cortisol, but consider the impact that the oral estrogen may have on the results. So these are some of the special considerations as mentioned in the guidelines surrounding the initial investigations for adrenal insufficiency in the NICE guidelines. Let's move on to case number 3. So case number 3 is a 45-year-old woman with history of primary adrenal insufficiency. She has been on hydrocortisone replacement therapy for the past 6 months. Presents to the primary care physician with several new symptoms. She has noticed significant and unexplained weight gain, increased appetite, difficulty sleeping. On physical examination, the physician observes thinning of her skin. Patient reports new onset diabetes and also increase in her blood pressure. Additionally, the patient has also developed a rounded face and a noticeable acne. So clearly, given this clinical picture, what is the most likely cause of her symptoms? Is it under replacement of steroids? Is it acute adrenal crisis? Is it over replacement? Is it primary hyperparathyroidism? Or is it thyroid dysfunction? So very clearly, this is over replacement of corticosteroids. So as mentioned in the guidelines, very important for clinical practice as well, we should look out for the signs of over replacement, which can be unexplained weight gain, increased appetite, disturbed sleep, skin thinning, new onset of diabetes or hypertension, Cushingoid appearance, look for skin infections and acne, look out for oral thrushes, look out for frequent fractures, and even height loss, which can happen due to the fractures. Signs of under replacement are opposite, they are weight loss, early satiety, decreased appetite, nausea, fatigue. Look out for worsening hyperpigmentation, especially in scenarios of primary adrenal insufficiency because of the high ACTH, muscle weakness, and in children, look out for abnormal growth rates and look out for the timing of puberty. So also monitor for mineralocorticoid losses or mineralocorticoid issues, especially in scenarios of primary adrenal insufficiency. Under replacement will be indicated by lightheadedness and salt craving. Over replacement will be indicated clinically by swollen ankles and high blood pressure. Biochemically, we can measure the renin levels and we should adjust the fludrocortisone doses if necessary if the renin levels are elevated. So this is something in terms of monitoring for the mineralocorticoid issues in a patient with primary adrenal insufficiency. General blood tests, blood pressure, measure both lying and standing blood pressure, regularly check electrolytes, monitor for sugar and cholesterol levels. In adults, look out for bone density and measure bone density at least once in the 5 years after diagnosis. So these are some additional recommendations in the guidelines. For babies, children, and young people under the age of 16, look out for the review any changes in personal or family circumstances, including education and training. check for symptoms of low blood glucose, regularly measure height and weight, track progression to and through puberty, including menstrual periods if relevant, measure bone age with an X-ray of the left hand and the wrist for those who are still growing, check for bone density once growth has stopped or if there has been any frequent low impact or unexpected fractures. As regards cortisol day curves or cortisol day series, the guidelines do not recommend to carry out cortisol day curves or cortisol day series curves to check for hydrocortisone dosing. So this is very clearly mentioned in the NICE guidelines, not to use cortisol day curves. Case scenario 4, a 40-year-old man with history of primary adrenal insufficiency is visiting his endocrinologist for a routine checkup. He has not experienced an adrenal crisis in the past 1 year. The physician is considering prescribing an emergency management kit. What is the best course of action regarding the prescription of an emergency management kit as per guidelines? Option A, do not prescribe an emergency management kit since he has not had a recent adrenal crisis. Prescribe one emergency management kit as it is sufficient. Prescribe 2 to 3 emergency management kits for safety, especially if he is traveling. Option D, prescribe an emergency management kit only if the patient requests one. Option E, recommend carrying only a steroid emergency card and no injection kit. So guidelines clearly mention now that we should prescribe the patient 2 to 3 emergency management kits, not one, for safety, especially in the event of he may be traveling frequently as well. But in all case scenarios, the guidelines now clearly mentioning prescribe 2 to 3 emergency management kits for the safety of the patients. So what does this adrenal management kit include and who should receive these kits? So for patients with primary and secondary adrenal insufficiency, provide 2 to 3 kits to each patient. Of course, we know primary adrenal insufficiency is involving the adrenals directly, and we know the common causes for Addison's disease, and in children it's congenital adrenal hyperplasia. Secondary adrenal insufficiency is usually caused by inadequate ACTH by the pituitary gland, often caused by treatment for pituitary disease or any tumors. Tertiary adrenal insufficiency is caused by inadequate corticotropin-releasing hormone production by the hypothalamus, sometimes because of treatment of tumors in the hypothalamus or adjoining structures, or more commonly because of taking glucocorticoids for more than 3 to 4 weeks, causing hypothalamic pituitary adrenal axis suppression. So this is something which we should keep in mind, because stopping glucocorticoids suddenly in this case scenario may again precipitate adrenal insufficiency. So if the patient has tertiary adrenal insufficiency in patients age 16 and over, consider kits. If there's history of adrenal crisis under 16 years of age, consider kits for all children and young people. So this is again all the recommendations as regards provision of the kits. As in our patient scenario, provide 2 to 3 kits to each patient. So what does this kit contain? Intramuscular hydrocortisone injection, premixed hydrocortisone sodium phosphate 100 mg per 1 ml, 1 vial, or hydrocortisone sodium succinate 100 mg powder plus 1 ml water for injection. Needles and syringes, you should provide 2 blue needles, 2 ml syringes for babies under 1 year, 1 orange needle and 1 ml syringe. Clear written instructions with diagrams and pictures for preparation, administration and disposal. We should also be including in the kit steroid emergency card. I will show you what are these steroid emergency card in the next slides. For glucose gel for babies, children and young people under 16, even a glucose gel should be included. An emergency management kit should contain, as I mentioned, and should always be given at least 2 to 3 to these category of patients. We should provide training how to use the kit, advise regular checks for the expiry dates of hydrocortisone needles and syringes, and replace as needed. Now, there are 2 types of steroid cards which are available, and that's what has the NHS advised. The steroid treatment card, which is the blue card, and the NHS steroid emergency card, which is a red card. To simplify, what is the difference between the 2 cards? So basically, the steroid emergency card, which is a red card, is given for the patients with primary and secondary adrenal insufficiency, and the steroid treatment card or the blue card is given for the patients of tertiary adrenal insufficiency. So a steroid treatment card, a blue card, is given to the patient with guidance on minimizing the risk when taking the steroids, also provide details of the prescriber. So we'll look at these details now on the next slides to give you a more simplified idea of the things. So this is the main difference between the 2 cards as per the National Patient Safety Alert. So as I mentioned, the red card given to the patients with primary and adrenal insufficiency, Addison's disease, children with congenital adrenal hyperplasia, and hypothalamic pituitary damage from tumors or surgery that are steroid dependent, including injectable steroids. Patients receiving intraarticular or intramuscular glucocorticoid injections who also use glucocorticoids by another route, like inhaled or oral. So there is a lot amount of glucocorticoid going on in this category of patients. So this can definitely, this category of patients should definitely get a red card, which is the steroid emergency card. All patients receiving exogenous steroids at the dose of prednisolone 5 mg per day or equivalent for 4 weeks or longer, and for 12 months after stopping oral glucocorticoids. All these are criteria to be given the red card. This is across all routes of administration, oral, topical, inhaled, or intranasal, as these patients are at increased risk of adrenal insufficiency. And that's why it's important that up to 12 months after stopping oral glucocorticoids, this patient should be given a steroid emergency card. Patients taking inhaled beclomethasone at the dose of 1000 microgram per day or equivalent of fluticasone 500 microgram per day or equivalent. This is because they are also at risk of adrenal insufficiency due to hypothalamic pituitary axis suppression. Patients taking more than 40 milligrams prednisone per day or equivalent for longer than 1 week, or repeated short courses of oral doses for patients on rescue treatment for asthma or COPD. Also, patients who are taking drugs that can affect the CYP3A4 metabolism together with the steroid treatment. In this case scenario also, we should consider giving the steroid emergency card. Those who are given blue card are those with patients with tertiary adrenal insufficiency on oral corticosteroids for a period of more than 3 weeks. If received more than 4 short oral courses per year, a card may be issued at the discretion of the prescriber or pharmacist. Topical and nasal steroids, if considered necessary by the prescriber, including dispersible tablets used as mouth rinses and sublingual tablets for the treatment of mouth ulcers. Inhaled steroids, steroid treatment class, the blue ones should be given at lower doses if there is a concomitant use of intranasal or topical corticosteroids, medicines that inhibit the metabolism of corticosteroids like the cytochrome P450 inhibiting drugs such as ritonavir, itraconazole, and ketoconazole. So this is important to understand when to give the red card and when to give the blue card. So that's the end of my freeview for this lecture number 80. If you like to have an access to the full session, please subscribe to my lecture series. You can contact me on my email, which is mazirules@gmail.com, and you can WhatsApp me directly on my WhatsApp number, which is 009715574344794. Of course, there is still many sections of these guidelines which are covered in my full session. This also will be including the doses which patients need to be given, also managing of adrenal insufficiency in a pregnant patient. So the whole session is quite lengthy, and it is covered in the full session recording for the patients. Thank you so much.